All right, welcome. I think we're right at 12:15, so I'm going to get us started. Dr. Troxler has a conflict today, so she's not going to be with us, but I will be facilitating, and I also have the didactic presentation. So I'm going to get us started with some introductions. So I'm Dr. Meredith Ginley. I'm a licensed clinical psychologist, and I'm an assistant professor in the Department of Psychology at ETSU. Dr. Copeland, could you unmute and introduce yourself?
Yeah, Chris Copeland. I'm a addictionologist with Revita Recovery at our Newport office. Glad to be here.
Glad you could come today. Dr. Tusharoni.
Hi, Dr. Tusharoni. I'm a postdoctoral fellow with ETSU Family Medicine. I'm happy to be here today.
Dr. Tusharoni will have our case presentation as well. So thank you so much. Check out how he does it. He's going to say it's really fun and not scary, and everyone else should do it too. If we can go around the room in the ETSU ADM Fellowship Zoom.
Hey, I'm Caleb Osborne. I'm one of the Addiction Medicine Fellows here at ETSU.
I'm Veronica Ray. I am the social worker and certified peer recovery specialist here.
Justin Owens, Addiction Medicine Fellow.
Thanks for joining us. Tanya.
Hey, I'm Tanya Milam. I am the medical assistant with the Addiction Medicine Fellowship.
Thanks so much. Jack Larson.
Hey everyone, I'm Jack Larson. I am a third-year family medicine resident at Kingsport ETSU Family Medicine.
Great, good to see you. Rachel.
Hi everyone, thanks for having me. I'm a clinical psychology doctoral candidate working up in Mountain City and happy to be here.
Thanks so much. Dr. Hayal.
Good afternoon, everybody. I am Cameron Hayal. I'm a psychiatrist, addictionologist, and associate professor in ETSU.
I know Melissa's in the IM Echo room, but I don't know how. You can go around. I don't know how many people are with you.
There's two of us here. This is our new educational technology coordinator. So if you want to say hi, Grant.
Hi.
And I'm Melissa Hood. I'm the educational planner for the program. And we will just remind you that if you have any tech problems to reach out to us. And if you just don't mind at the very end to complete your evaluations, and that just helps us plan for our future sessions to better help you all.
Yeah, if you complete the evaluation at the end, you have a section where you can write in like, these are topics I want them to cover in the future. So that's a great chance for you to tell us what you would like us to present on. Ernest Maupin.
Hello, my name is Ernie Maupin. I'm an assistant professor at ETSU College of Nursing, and I'm the project director on our nurse practitioner residency grant.
Michael.
I'm Michael Mishka. I'm a psychologist and clinical director for behavioral health operations at TenCare.
Thanks so much. Katie Langley.
Hi, I'm Katie Langley. I'm a psychiatric mental health nurse practitioner and doctorate student at ETSU.
Thanks. Suzanne.
Hey, I'm a psychiatric nurse practitioner at Alliance in Memphis.
Welcome. Are you both Suzannes? One's you're on the phone and one's your computer? Or is there two Suzannes? Suzanne Stovall?
Yes.
Okay. I think, yeah, your video is one block and your audio is another block. All good.
Okay.
I don't know. Melissa maybe can figure that out. But we can hear you and we can see you, so that's great.
Okay. I might log out and log back in. There's a lot of feedback.
Oh, okay. Sounds good.
Yeah, if you can log back out and just make sure that there's not two Zoom windows open, because it seems like there may be two the way it's feedback with that too.
Okay.
Brooke Claiborne.
Hey guys, how are you? I'm Brett Claiborne. I work with Mountain Peoples. I'm their behavioral health MAT, SUD case manager, and addiction grad student.
Great. And Rebecca Singleton, I don't know if you're at your computer. You're able to.
Yes. Yeah. I'm an NP resident working in the Mountain City Clinic.
Great. Thank you so much. All right. So welcome everybody. So today we're going to be talking, our didactic presentation is going to be about motivational interviewing. So let's set up that screen share. Actually, start at the beginning. All right. So I have no conflicts of interest to disclose. So today I'm going to be doing an overview of the topic of motivational interviewing. I'm trying to do kind of like a few thoughtful, kind of digestible like bites to kind of showcase a bit of the look and feel of MI. But this is a really, really, really cursory overview. Unfortunately, you're probably not going to be able to just go do MI after a short talk like this. But I have a bunch of resources at the end for places that you can go to get more training, if that's something that's of interest. In the end of my slides, there's lots of ways to access more. So motivational interviewing is going to be an approach to counseling that is designed to kind of help people examine and accept reality. And it's supposed to be, it's kind of emphasized specifically like an uncomfortable reality. So for substance users, that uncomfortable reality is usually that they need to stop using or they need to cut down their use. So when we're asking, when someone's asked to kind of consider quitting a drug, which is a behavior that's not only going to be physically addictive, their body might be like chemically dependent on it, but it's also going to be a behavior that's woven into the fabric of their life, maybe even into their very identity. The individual is going to likely respond with some sort of defense. And this defense will come up even if quitting is something that seems like the right thing to do, right thing for them to do, and it's going to be most in line with their goals. And defense is a word that's intentionally a bit different than that word denial that we might hear in AA framed presentations. Defense is going to be this kind of natural, expected response. Think of defense as, you see something out of the corner of your eye that looks like it could be a snake, and our natural instinct is to kind of go like, oh, snake, and check it and see if it's actually a snake. That's defense. So the guiding principle of motivational interviewing is that defense is normal, and as a result, confrontational approach will bring out resistance. So we want to engage people in a way that we encourage them to kind of express their own reasons for moving towards change, and we don't create more resistance because defense is already going to be natural and something that and change is going to be hard. Change is hard for humans. So the spirit of MI has a few there's kind of motivational interviewing is both a specific intervention that you can do, kind of like a one session specific intervention. There's motivational enhancement treatment, which is about a 5 session specific intervention. But then there's this general just spirit of MI that we can use in any of the interventions that we do, anytime we work with an individual. There's a few key tenets to this spirit. So that motivation comes from the client. It's not imposed from others. So we can't tell someone what to do and have them want to change. They have to want to change themselves. And that it's the client's task, not the counselors, not the physicians, to articulate and resolve any ambivalence around change. Direct persuasion is not an effective method for resolving ambivalence. So no reality television show intervention sit-downs. That doesn't work. Instead, the counseling style is going to be quiet, eliciting, letting the client be the expert in the room, the expert in what's going on, and that they're the one that's going to do the work to examine their own ambivalence and examine their own reasons to change. Also inherent within this is the idea that readiness to change isn't something like that's a client trait. It's a fluctuating product of interpersonal interactions. So we can make someone more ready to change by talking to them and listening to what's going on. And then also within MI, the therapeutic relationship is seen more as a partnership, and individuals kind of walking alongside of each other as opposed to this expert and recipient type role. Both persons in the room's opinions and perspectives are valued, if not the client's valued above and beyond. So within this sphere, even if someone is, say, court referred and coming to you because it's therapy or go to jail, you can often still find a reason why they might want to change. And it might not be that they want to change substance use, but it might be that they want to figure out how to not go to jail. And you can use that to build motivation and move forward towards goals. So how do people change? How do we move from being person A that does X thing to person A that doesn't do X thing? So change occurs naturally. So if you look at the natural recovery literature related to substance use disorder, about at least 50% of people with a use disorder change on their own without any intervention. They don't necessarily go to an AA meeting. They definitely don't present to inpatient treatment or even outpatient psychotherapy. Instead, change seems to happen because of kind of this observation that like who I am isn't who I want to be anymore. I see myself as person A, and what I'm doing isn't aligned with that. And often that observation, that awareness is created because of interpersonal interactions. So the people in my life don't like how I am now. My loved ones are being let down because of my actions. So we can make that natural change process kind of ramp up and happen faster through therapy by creating empathetic, positive interactions that highlight why change could be so beneficial to that individual, why change is so important, and how being able to change could get that individual back to their true self and who they actually feel they are. So change seems to arise when the person connects change to something that's intrinsically valued by them, something that's important, something that they cherish. And this motivation is most likely to kind of manifest and take root in atmospheres where it's safe for the person to explore why they want to change, as well as explore kind of how painful it might be to change. So this is just a quick snapshot of the stages of change model. I think you probably are all pretty familiar with this, but just including this here because the idea that people come to treatment are often in different places in their readiness to change certain behaviors. And the caveat to this is that you may have someone who is in an action stage around their opioid use disorder and engaging actively in medication-assisted treatment, but they're in pre-contemplation around their meth use. So we know that the continued meth use will threaten their overall recovery and health. So we may be engaging in motivational interviewing specifically around the meth use and kind of just helping them maintain as related to their opioid use disorder. So you can bring in MI anytime you kind of have fluctuation in motivation, even if some things are going really well, there's still room for it. So how do we do MI specifically? So there's 4 foundational processes in MI, and they're somewhat linear, but not always. Sometimes it's that kind of 2 steps forward, 1 step back. So the first step is engaging. So just like, can we talk? Shall we talk? Then we go to focusing. What is it that you want to talk about? What is it that's most important? Evoking, which is where we're trying to ask why this change is important. What is the person's own motivation for change? And then once we understand why the person might like to change, we move into this planning phase where we really concretely, step by step, break down how do we go about this change process for you. So those are the overall principles of how a session looks. And these next few slides are focused on the general principles of how we say things and move into that plan. So one of our main areas is expressing empathy. So whatever is going on with the individual, we empathize with it, and that acceptance can facilitate change. We recognize that ambivalence is normal, and we can empathize even with that. We also develop discrepancy. So we want the client to be presenting the argument for change. We want to be listening to why what they're doing now isn't working for them, what's causing them pain, and where is their hope that we could move them towards. We also roll with resistance as part of MI. We never want to directly counter. So even if something comes up and a person says, absolutely no, I would never make that change, you just reflect. I hear that would be a really hard change to make. You never say like, no, but you have to, even though that might be what your brain is thinking. Whenever we see resistance in the client, that's our signal to respond differently, to not challenge, but to say, okay, something's here. Maybe we should circle back to this later, but let them move on. We also want to support the client's individual self-efficacy. It's important for them to believe that change is important and that change is possible. We also want to help them avoid self-fulfilling prophecies. So when someone points out that, whenever I've made a change, it's ended with me relapsing before, I try not to move them off that talk and remembering and rehearsing their previous relapse. Instead, I want to ask them about a time they've made a big change and it's worked, even if it's a big change at work or a big change with how they're taking care of their kids, and explore what works, and build their self-efficacy around, like, you can make changes, you can make hard changes, and be successful. These are some key elements to help create motivation. So with pre-contemplators, those not thinking about quitting, and contemplators who are considering quitting but not fully committed, we can ask perceptions about both sides of the issues. So what are some good things about your use of opioids? What are some less good things about your use of opioids? We can talk about, how does opioid use fit in your life? And then the other side, what ways does opioid use not fit so well? Being able to kind of put into the room some of that discrepancy, so then you can start to reflect and rephrase and zero in on the areas that could be moving towards change. So we use reflective listening extensively, and you're repeating and paraphrasing with reflective listening, but you're doing this with a specific goal in mind. You're specifically trying to increase discrepancy and reduce ambivalence. So the statements that you reflect, you don't just reflect everything they say, you reflect the statements that are going to be most in line with change. So you think about, I always kind of zero in on, statements about helping their family, acting more in accordance with their faith, returning to their true selves. Those things that we know, having talked to individuals who've been in recovery long term, have identified as the reasons that they've been able to sustain long-term change. Use affirmation. So affirmation, reflecting the client's strengths, can be really helpful for building rapport. Sometimes this is particularly helpful with people who are mandated to come in or really unsure about why they're even there, if they even want to change. So you can even just affirm that the person is actually sitting there talking to you, instead of just sitting silently or not showing up for the appointment. You can always find something to affirm, and that can build rapport and get them talking about next steps. Use of summaries can be really helpful when you have heard a lot of information from the client and you are able to kind of summarize everything, break it down, and when you make the summary, you're deciding as the therapist what you're going to include and what you're going to emphasize. And you don't include everything. You include the things that are going to be most helpful in helping transition from, I have this concern, I don't know what to do, and let's identify the problem and let's move towards fixing this problem. So we're going to summarize, say, we identified this problem as not having a job. We do a summary, say, let's figure out what steps we need to take to get that job. We elicit self-motivation statements. We ideally are kind of trying to create this environment where we're setting up the client to say, wow, I really need to change. This really isn't working for me. I'm not acting in accordance with my goals. Things would be so much better for me and my family if I were to stop X. I want those words to come out of the client's mouth. If they hear it from me, it's not the same as if it's their brain, their internal talk system that's created that decision and is now now shifting within themselves. It's much more powerful coming from in their own words and from their own heart. So things to remember. Being uncomfortable about change is human nature. This isn't a character flaw in your client or your patient. Like, we know that change is hard. Diets are hard. New Year's resolutions are hard. Why wouldn't this be any different? We also want to remember that client goals don't always match counselor goals. So the client may want to reduce their use. You might think abstinence might be better, since harm reduction models haven't worked for them in the past. But you roll with the resistance. You can let them set their own goals, even if you, as the expert, kind of have strong opinions. We want to keep a broad view of things, thinking about life goals. So how can we think about kind of big picture? This can be where harm reduction comes in. This can be where focusing on long-term planning and highlighting long-term planning can be particularly important. We also want to think about whether or not a goal is realistic. And our place here isn't to like shoot down goals, but to focus on planning so that the individual has outlined the steps to be successful and to get there. I always think about when I worked in a federal prison for a bit, and a lot of the inmates I worked with wanted to be entrepreneurs, which is a super hard path in life. But it's also an accurate reflection that it's really hard to get high-paying jobs with a criminal record. So I would never shut down directly and say, like, that's way too hard, you could never do that. But instead, I'd be like, wow, that's really challenging. Let's spend a really ton of time setting goals around the skills that you need to get there. So do you need to finish your high school degree so that you can know the math about how to keep your own books? So however large the gap between the current and the future is, you can appraise the reality and use it to make sure the steps to get there are as helpful as possible for success. Counselor suggestions with permission may be helpful. Within MI, you're not the expert as the counselor, and we don't tend to give too much of suggestion kind of wise ideas. We don't prescribe, but sometimes you have a really good idea, and you can, if that's the case, you can say, with your permission, I have a resource that might be helpful. Would you like me to tell you about it? And give them the autonomy and the opportunity to say yes or no. Don't do this too much, but you can, with permission, offer expert type advice. And then it can also be helpful to think about in your planning, not only barriers that related to adverse outcomes, but also what could go right. Like, how do you achieve success and keep achieving success as things start to go right? So this is the most recent version of the motivational interviewing book. I highly recommend this. This has lots of examples. It's a pretty accessible read if you've not read this one already. And then lots of great resources on this topic out there. These are a few online resources. I teach a bit more on this topic in different settings. And then I'm always happy to listen to tapes if people are wanting to try motivational interviewing. You can talk beforehand, think about confidentiality and whatnot. That is all I've got. Questions about motivational interviewing? All right, the pauses. I think we've had Timothy Belbrook joined us. If you'd like to unmute and introduce yourself before we move on to the case.
Hi. I'm I'm Dr. Bill Brook. I work with Alliance Healthcare Services in Memphis, and I'm board certified in psychiatry and addiction medicine.
Great,
Work
thanks.
community mental health.
Thanks for joining us all the way from Memphis. And then Conwee D. Don't know if that's your last name, first name.
Hi, my name is Conwee Carmen. I'm one of the family nurse practitioners, a part of the ETSU Nurse Practitioner Residency Program.
Great, thank you so much for joining us. All right, with that, I'm going to turn us over to Dr. Tusharini, who's going to present us about a case that he's been working with, I think, for a while now, he told me.
Yeah. This is a case that I worked on for most of my internship. So I first met this person, I think, in late August of last year, and worked with up until the very day, my very last day at internship, right at the end of July. So the kind of a long history, lots of moving parts to this. The central thing that I'm hoping to explore today is what this treatment would have looked like in a primary care setting versus how we handled it in a community mental health setting. So that's sort of the lingering question that I don't have an immediate answer for, but I would love to hear some discussion about when the time comes. We'll call her Mary. Mary was a 54-year-old woman of Cherokee descent who I first met in the crisis stabilization unit that was attached to the clinic where I was working at the time. And she was presenting with schizoaffective disorder along with substance use disorder. Her primary problem substance was methamphetamines. And so she was on and off with that. And then there was a history of alcohol abuse that wasn't so much a factor by that time. And then some fairly frequent cannabis use as well. Mary had a trauma history that began very early in life, and that included physical abuse, emotional abuse, sexual trauma that was chronic and ongoing throughout much of her early childhood, to the extent that she had a lot of trouble remembering much of her childhood. When she was around 10 years old, she attempted to burn her stepfather's house down by pouring a bunch of flammable liquid all over the place, and was caught trying to ignite it, and ended up becoming a ward of the state for a while. And her telling of the story, she was locked up for trying to make the abuse stop. Her stepfather, she feels, there was never really any justice there for her. So she didn't feel that he was adequately punished for the abuse that he subjected her to. And it was him and his sons as well that were abusing her. She more or less got on the trauma train pretty early in life and never quite got off of it. So by her mid-teens, she had developed a substance use disorder. She went from alcohol to cocaine to opiates, and by her 30s had settled into a fairly consistent methamphetamine use. When I met her, this was her history. She had just a few months prior to that lost her partner at the time in a fire. He was he had set himself on fire, and she had sustained some burns trying to rescue him from the fire, and tried to pull him out of the house, but she couldn't make it all the way, and ended up having to drop him and get out of the house. And prior to that, she had a long history of physical abuse and inter-partner abuse, lots of violence, like lots of intimate partner violence. So what I encountered with her was a very long, varied, and complex trauma history, a long and varied substance use history, and then coping with the realities of living with schizoaffective disorder to boot. So I met her. She was in and out of the crisis unit quite a lot. Like every couple of months, she would be there for a little while. And over the time that I worked with her, both as an inpatient and as an outpatient, there was a pattern that emerged where she would seemingly be making some progress. She would stop doing the math for a little while. She would attend our therapy appointments fairly regularly. And she seemed to be putting a lot of work into recovery. And then some stressor would come along. And she had a very, very pronounced stress reaction too. So a lot of poor impulse control. But something would set her off, and she would revert back to methamphetamine. More often than not, it had to do with a gentleman that she had been dating after she lost her partner, who was very physically and sexually abusive, who would come around to where she lived, and if he caught her outside, would harass her and sometimes physically confront her. She was scared to press charges out of fear of retaliation. So she would start doing meth in order to stay awake. And she would tell me that it was comforting to her. It made her feel safe to be awake so that she could be vigilant against this person coming by. And then she wouldn't sleep or eat for days on end and become increasingly dysregulated. She had visual and auditory hallucinations, including a lot of command hallucinations. And these would begin to ramp up in the absence of sleep or nutrition, to the extent that she started to exhibit a great deal of suicidality, at which point she would contact me and be kind of coy about it. Like, I think I'm in trouble, or something's going on, but I don't want to tell you because then you're going to lock me up, etc. And it became this sort of, I don't want to say game, but this regular interaction that I would have with her, where I would try to work with her to get her to disclose, and then to try to get her to come down and do a crisis report and go get medically cleared and come to the unit so we could get her stabilized. She'd be there for a couple of days and then would leave against medical advice. And this would happen over and over and over again. In addition, she often would attempt to sort of monopolize my time too. So we'd have weekly appointments, but she might call me 2, 3 or more times out of the week. She might show up at the clinic, sort of bypass the front desk and come straight to my office. And the thing, she'd been a regular fixture of this clinic for years before I ever came along. So lots of people had worked with her. Lots of people had different opinions or attitudes about her, including colleagues who had just sort of written her off altogether. So it's difficult to find professional support in my treatment of her. There were numerous suicide attempts. There were periods where she would just sort of disappear off the radar for varying lengths of time. Lots of cutting and lots of fixations on starving herself to death. So she had this plan where she would just stop eating altogether and then go out to the woods where nobody could find her and just allow things to happen as they would. And then we got to this territory of some homicidal ideation where she started to sort of stalk the streets with a weapon looking for her ex. And she was very much perseverating on this idea of taking him out before he could get to her because she felt that she had no real legal recourse. She eventually pressed charges, but then was she couldn't bring herself to testify against him in court. By the end of my time with her, she'd been diagnosed with Parkinson's, but it was a misdiagnosis. What was happening was tardive dyskinesia was setting in. And this is after years and years of antipsychotic medicine. The treatment approach that I took with her was very much ACT oriented, and I try to draw everything that I'd learned up until this point about trauma-informed care. So it was a very slow going treatment. It was kind of like trying to make friends with a cat, right? Like you can't just chase a cat down and you can't tell a cat what to do. So it was very much an initial process of establishing trust and just providing a safe environment in which she could get in touch with what was going on and communicate and express herself freely without judgment or pushback. And what my primary focus with her was essentially trying to help her to slow down a little bit. She's very, very, like I said, very, very reactive. So very sort of immediate limbic response, and that was easily provoked. We would make some really great progress here and there. But again, there was so little control over what was going on outside of the clinic and in between sessions that, sometimes we would take 2 or 3 steps forward, very significant steps, all these celebratable breakthroughs, and then she would relapse and take 5 steps back. So and then there was a point where she was telling me that she would hallucinate in my presence. So she would be on the verge of making a decision as to whether or not to use or whether or not to leave the clinic, and she would sort of see me there and hear me sort of counseling her or advising against using. And I that was a first for me, and I wasn't really sure exactly what to do with that. So when I left, it's hard to really quantify or qualify where we were, if there was a net gain overall. She'd gotten a lot more comfortable talking about trauma and processing and unpacking events in her life. But a lot of those external stressors were still very much a factor. Where we were in sort of rural Appalachian Ohio, there just was not a great infrastructure or continuum of care for somebody in her position. So we really didn't have a lot to work with aside from what we could accomplish within the therapeutic dyad. What stands out, I mean, a lot of things stand out about this person, but the longevity of this relationship and her tenacity, for one thing, and she did have buy-in. I mean, it was definitely a part of her that wanted to live and that wanted to recover, and we began to develop this sort of vision for what her life could be, and that was very much determined by values. So we did spend ample amount of time kind of cataloging and making an inventory of her values and what was important to her and what was meaningful to her, and then finding ways for her to feel safe enough to sort of move in those directions. We had the luxury of time. Like I said, this was a community mental health setting, so there was no real cap, no real limitation on just how long she and I could work together. I find myself wondering what would happen here at Johnson City Family Medicine. If I were to encounter a person with just this complexity of presentation and needs and risk, where, you know, at most I might have 6 sessions like it's been with a person in general. So any questions or any need for elaboration or any thoughts would be greatly appreciated.
All right, thanks. I'll take a moment to summarize that case, but I think Elizabeth Childress, I think you joined us since we'd like to.
Yeah. Can I leave my video off? I just got back in town from Memphis for a visit.
Absolutely. Just just introduce yourself.
Oh, okay. Hi, I'm Elizabeth Childress. I am still expert coordinator at ETSU, but currently on medical leave because my son was diagnosed with high-risk neuroblastoma. So we've been at St. Jude, but happy to be with ETSU and enjoyed my time with the family medicine and implementing expert there. So it's good to see everybody.
Thanks so much for joining us. I'm sorry to hear about what's happening with your son.
Thank you.
All right, I'm going to do a quick summary of Joey's case. She was a 54-year-old Native American woman with schizoaffective disorder and active substance use disorder of methamphetamine, but also as well as a history of alcohol use disorders and cannabis use, maybe reaching threshold of substance use disorder. They met in August of 2020 in crisis stabilization, and he worked with her, sounds like at least weekly for over a year. This individual had an extensive trauma history, including chronic sexual trauma and a time in state custody. She also has a history of, since childhood, of traumatic events, including interpersonal violence. She was in and out of crisis stabilization, lots of kind of recurring pattern of she would stop using and then she would get mixed back up with a previous abusive partner and would start using again in order to stay awake, to keep herself safe from that individual. And then she'd be awake for so long that she'd begin to hallucinate and become suicidal due to that lack of sleep and extensive drug use. And then she would return to treatment. The system that she was in, both kind of the system they had in the rural Appalachia region, where the clinic was located, and then the specific clinic where she'd kind of burned through the empathy of a lot of the providers there, made it hard for this individual to access care. She had extensive medical use of antipsychotics to the thresholds where she was experiencing symptoms of tardive dyskinesia. Joey did a really long-term intensive intervention approach with her that included both acceptance and commitment therapy and trauma-informed, trauma-focused care. This individual terminated treatment with Joey because he left, he finished his job there, and he found that there was kind of unclear gains while she was more comfortable with talking about trauma. The stressors of her life were so all-consuming. It was likely that she would continue on this trajectory of return to use and return to extreme symptoms. His question for us as a team is, how do you treat someone with this much complexity were you to be in a primary care setting where you do not have as much time as he had, but also maybe have additional resources available to you that because of their system he did not have available to him. Is that anything else you'd like to add there?
That's pretty spot on. Thank you.
Right. Any clarifying questions about this case?
I have a question. Go ahead.
Sorry, Rachel.
Mine's brief. I was just to answer your question, going back to how to give proper care in a primary care setting for such a complex case like that. I feel like that I see Definitely not that complex up here in Mountain City often, but I think it's just so important to like establish the different treatment teams. And so, Joey, I'm not sure what you were kind of experiencing within your setting, but just trying to get them equipped with so many different types of people. So counseling, medicine, social work, just within the community. So they have kind of a team, because I can't give them any type of long-term care. But that's just kind of what I was thinking there.
Thank you, Rachel. That's this idea of sort of wrapping somebody up in care and wrapping them up in services is so important. She needed support from every angle, and one of the big problems that we encountered, and it's kind of a two-pronged problem. One is that there just wasn't a lot of that there for her. Two was there was a sort of really three-pronged. Two is that people that she had been working with, as I mentioned, were just burnt on her and did not really approach her in the spirit of, I guess, recognizing or affirming her capacity for improvement or change. And she was cognizant of that. And then three, and stemming from two, is her sort of persisting reluctance to engage what resources we had. I mean, she would go to primary care and she would take medicine for the most part, but if she found that it disagreed with her on any level, it was really hard to keep her compliant with that treatment. But yeah, I appreciate that, Rachel.
I have a question actually. Did she ever had, given the fact that she started using some substances age early at 10, had any time independent to use of the substance having a symptoms of the schizoaffective or schizophrenia that was diagnosed?
According to her, yes. She'd have periods of non-use during which the more positive symptoms of the schizoaffective were there. I mean, she chronic mood dysregulation, and by her account, the visual hallucinations were sort of perpetual, sort of always there, regardless, use, no use. And the same for the auditory hallucinations. When she would be on the meth or and then sleep deprived and practically starved, that would exacerbate them. They get a lot worse. But there was sort of a constant baseline of psychotic symptoms present.
To build on what Rachel had said, I think one benefit of having the team-based care in the primary care setting, you do lose that benefit of like, hey, we got all sorts of time, because that's typically not the case in a primary care setting. But if you've got somebody who's meeting with you once a week and they know I'm going to go in and I've got to gear up to go 12 rounds and this is going to be hard work. Depending on where they are, they may come in already kind of with their guard up. And so when you have someone who's able to see so many different, different team members, you may get them set up with their primary care appointment and they're coming in without that guard up. And it's like, hey, I'm going in for my appointment, but they're still getting, we may not be like, hey, let's dig into your trauma history today, but they're kind of getting that wraparound where it keeps coming up in different settings. And so you're able to have it addressed. And so if you're also having those conversations, having clinical conversations with the rest of the team about the patient, and they're aware of what's going on, which ideally is the case in team-based care, then, they can continue to probe and have some of those conversations with them, maybe in a setting where they're not already coming in with their guard up.
Joey, I know in our primary care setting, we have multiple team members. We actually have behavioral, we call them wellness coaches, which is LCSWs and LPCs on staff. And then I'm one of the behavioral health case managers that we have. Plus we have substance use disorder, MAT. We offer all of these in our primary care setting. My office is right next to the primary care setting. One of the things that I wanted to bring up, the way that we do things when we coordinate, we kind of screen to see which one is, I don't want to say worse, but which one is more present, whether it be their behavioral health or their addiction, which one is affecting, and then we kind of work our way down from there. As we go through that, if we see that the patient needs more services than what our wellness coaches can provide, or how I can intervene, or how the primary care intervene, what we do is we keep the patient as a primary care. They still get counseling and case management with us, but we actually link up to another community mental health center for medication management if we feel that they can't get that particular service, because we do offer behavioral health medication as well. Our primary care physicians do that too. And we also are looking into the genotype testing. I don't know if you're familiar with that or not. We have a nurse practitioner that actually just done it. And I'm working with her very closely on some of our behavioral health patients, because they've tried 3 or 4 and we're to a point that their symptoms are getting worse. So I think for us as a primary care setting, being in a rural area, when you don't have a lot of access to care, you kind of have to put your heads together as a team to figure out which one is worse for the patient, but which one can we treat right now? And then can we trickle down to what is worsening after we get the one kind of worked on, not fixed, but worked on.
That's great. So in the sort of the absence of having this very extensive toolbox, so to speak, of services within the community, you're saying that as a team, you had to be creative and you had to sort of think progressively about how are we going to best leverage the resources that we do have. And I'm hearing there's a lot of leaning on one another. And that made me think of a lot of the attitudes that I encountered with regard to this patient while I was up there, given her history. And like, make no mistake, she was a difficult person to work with. And so that whole unconditional positive regard piece really did get pushed on my end. So I'm wondering, when I was listening to you, I was wondering about different strategies people have maybe used in the past, especially within a team, to support and bolster one another, because that whole compassion fatigue thing is real. And I saw it happen and even felt that tug myself against every instinct that I have, and against every intention that I have. So I'm wondering if anyone would like to speak to how do you maintain that, and how do you support other people on your team who you are recognizing are reaching their capacity, their saturation point, essentially.
I feel like I love that you brought that up, because I feel like that's not discussed very often. But first and foremost, I noticed that as well, especially with my borderline clients that come into primary care, and my inability to do full model dialectical behavioral therapy. I just have to tweak it to be able to do brief interventions. And it can be really frustrating when you're not seeing any improvement, when you don't have the actual treatment that you need. And especially with borderline clients, they can be very difficult. So I think that's, again, like where you were mentioning that treatment-based approach, like just being able to talk to your colleagues about what's going on. And then also, like was previously mentioned, that triaging. So especially with borderline clients or any other clients that come in with so many different problems, I try and just be very clear and direct and be like, by the end of today, we're going to be discussing this. And then next time when you come back in, we can discuss this, but we're just going to focus on this one thing today. And I've noticed that kind of helps, because then as a practitioner, I feel like, okay, I was able to help with one thing today, even though they have a lot of things that they need help with, which is fine. But I feel like that helps me just a little bit with that fatigue, and it keeps the client on task as well. But that's really the only thing that I've been able to find that helps. I don't know.
Rachel, are you at the prison?
No, I'm up in Mountain City.
Okay, I'm sorry.
Also, great to see you.
Yeah, I know. Things going well for you?
Yeah. Applied to internship, waiting to hear back.
What a march through hell that process is.
Oh, I know.
But good segue there. Like my friend Rachel here is going through one of the most stressful parts of a very stressful training program. And so it's easy for your cup to get empty, and life does keep happening. So, I'm working with this person and trying to finish my dissertation, and I'm thinking about postdocs, and I'm still trying to find, and I've got 20 assessment reports I've got to finish, and I'm still, and a pretty big caseload to the point where I'm not really taking lunches anymore. And I'm trying to still be an effective parent and an effective partner. And it's a lot. So it's easy for your cup to run out. And that's another thing with these clients that really do, it takes so much energy and focus. And so that's a really important piece there too, is how do we fill our cup? And in some places where I've practiced, there was no real support. There's no, like I did an externship at FTHRA. So it's me and a bunch of corrections officers, parole officers who don't have the same kind of perspective on the clientele, the people there, that I do coming in as a therapist. So there are situations where you don't have that support, and then we have to figure out, well, how do I do for myself? How do I rake in a little bit of self-care and peace of mind for myself? And that's a difficult place to be, for sure. So I appreciate your input there, Rachel. And would love to hear some other thoughts.
Yeah, it sounds like we've heard at this point, we've gotten recommendations around kind of, because you'd be able to see this client in a primary care setting, you'd have potentially a much bigger team to pull on that could allow you to do the wraparound care services in a manner that would maybe be not so much all on you and not so dependent on you being able to see the individual for large blocks of time, week after week after week. And then also that perhaps being part of a bigger interdisciplinary team would help address some of your compassion fatigue type concerns across the providers. Do others have any other ideas about how to work with an individual with this level of complexity as part of primary care?
Well, I just reflect on that fatigue that you mentioned. One of my mentors told me once, and I like that statement, says, when you find yourself, you're working harder than your patient, you need to reevaluate the situation. That's it. You are helping the patient to recover from the substance use or recover from any mental illness, and the patient needs to do more work of the things on that one. So I think that if you find yourself that you're getting so tired, reevaluate the situation and approach it in that point.
Yeah, I did at one point, maybe more than one point, I think I said something to the effect of, like, I cannot work harder on your recovery than you are working. I can't do this business of recovering for you. Like, I can give you guidance, I can try to orient you in a positive direction, but I cannot do the work outside of here for you. And that's kind of a difficult thing in its own right. It's a difficult thing to tell somebody that you're actively caring for, that you do care about. But it's also a way to sort of humanize yourself and where you are with that person. And that's an important thing to convey, I think. This is the impact that you are having on me. and we need to address that. We need to suss that out. I appreciate that, Dr. Haya.
I think we're just about at time. I think I do see I think I see 4 people now in the ADM fellowship room. If we missed somebody.
Hi, my name's Mary. I'm a 3rd-year medical student. I'm on a 2-week elective at addiction medicine.
Okay, Mary. And then Dr. Troxler got here.
Hi, it's okay. Yeah. Are you muting it?
She's here.
Okay.
And then Rebecca Singleton, I think either I missed you or you.
Oh, I was already on here.
You're already on here. Oh, sorry.
Mm-hmm.
I just didn't write you down on my page. All right. That's time. Thank you so much for joining us. Thank you so much, Joey, for giving us such an awesome case to be able to discuss.
Sure. Thank you all for your thoughts and your guidance. It was really helpful to me, and I appreciate it. Thank you for your time.
See everybody in 2 weeks.